I want to welcome everyone to today's NIH Office of Dietary Supplements seminar. I'm Barbara Sorkin. In addition to organizing ODS's seminars, I co-direct the NIH's Consortium Advancing Research on Botanicals and Other Natural Products. Before I hand over to the ODS director to introduce today's speaker, a few brief announcements. First, our coming attractions. Our next ODS webinar will be on Wednesday, November 20th, also at 11 a.m. U.S. Eastern Time. It will be given by Dr. Harris Lieberman. Dr. Lieberman will be talking about dietary supplement use in the military and what we can learn from that. If you are not on our seminar's mailing list and you'd like to be, please see the chat. You should see your chat icon at the bottom right of your screen. I'll be putting an email address in the chat that you can use to request to be added to our ODS webinars mailing list. Next, some webinars logistics. In the interest of audio quality, we have muted you all on entry. And we ask that you please stay muted until the final questions and answers. You do have access to the chat, and please feel free to put your questions for Dr. Phillips in the chat as they arise. If I see any that seem really urgent, I'll try to get his attention to ask them. Otherwise, we'll take as many as we can fit at the end of the presentation. Please also use the chat if you're having technical problems with the webinar audio or visuals or the closed captions, and one of us at the NIH end will try to help. And just one more caveat. And with that, I want to hand over to the Director of the Office of Dietary Supplements, Dr. Stefan Pasiakos, to introduce today's speaker.
Thank you, Barbara, and welcome everyone today. It's great to see such a large group turned out for our seminar series. We have an honor today of hosting Dr. Stuart Phillips. Stu is a big deal in the area of skeletal muscle, dietary protein, supplemental protein, and exercise. So I'm very honored to have him here today. So let me introduce Stu, and then I'll just share a couple of personal tidbits about me and my relationship with Stu over the years. So today we have the pleasure of hosting Dr. Stuart Phillips. Stu is a distinguished university professor in the Department of Kinesiology and a member of the School of Medicine at McMaster University. He is a Tier 1 Canada Research Chair in Skeletal Muscle Health. His work centers on the interaction of exercise, physical activity, aging, and nutrition in skeletal muscle and body composition. He is a Fellow of the American College of Sports Medicine and a Fellow of the Canadian Academy of Health Sciences. Impressively, Stu is among the top 1% of cross-field, highly cited scholars globally for the past 6 years with his work in nutrition and physiology. On a personal note, I have known Stu and known Stu's work since I was a graduate student 20 years ago. Like Stu, my work has focused on the role of dietary and supplemental protein on skeletal muscle. Stu has always set the high bar for us up-and-comers in the field. For us looking to make a name for ourselves. I've always admired Stu, not only for his ability as a scientist, but more importantly, for his ability to actually teach and mentor the next generation of scientists who really hope to take his work and move it to the next level. His students have all gone on to do great things, and his interactions with me and some of my postdocs have really helped us make advances in our field and help us progress in our careers. It's been a privilege to learn and work for you over the years, Stu, and I'm grateful for the opportunities when we have had the chance to work together. And I'm thankful that you're here with us today to share more about your work and current insights on protein and muscle in the context of exercise. So thank you, Stu, and welcome.
Thanks very much, Steph. Really appreciate it. Very generous introduction. I'll just start sharing my screen here if I can. Just want to make sure everybody's seeing the slide there before I begin.
It looks good, Dr. Phillips.
Okay, awesome. Great. So it's a pleasure to be here today. Thank you to all of you for taking some time out of your day to listen to me. Hopefully I'm going to give you some new information, but I'm going to go over probably some older information, and hopefully it won't be too repetitive. Just some funding and disclosures to begin with. On the left-hand side of your screen, you'll see some of the agencies that support the work we do. On the right-hand side of your screen, you'll see some companies that have paid me honoraria for speaking and travel expenses. I also owned 2 patents that are licensed to Exerkine, but all of those relationships are held in a blind financial trust, and I receive no financial inducements for that. But I don't think that that's going to play a role in anything we're going to talk about today, but I just wanted to make it clear. So before we get started, I really do just want to acknowledge the people that really make it happen. As Steph says, I'm really proud of the people that have come through the lab over the 27 years that I've been at McMaster. And it's really those folks that do the hard work. They're the ones in the lab, and through their hard work and experimentation and essentially listening to me, I look good and their reflected hard work. So it's a real credit to them, and you'll see some of them as we go through this presentation. There's too many here to talk about, and we do lots of things, but you'll see a few of them. So the learning objectives for this presentation are hopefully that on completion, you will be able to identify the key roles that skeletal muscle plays in optimal health, particularly in aging, and to explain what happens to muscle with increased loading, and at the same time to have a little look at what happens with disuse, and to look at strategies to prevent loss of muscle in aging and hopefully slow the trajectory of age-related sarcopenia, to review and explain why muscle disuse is such a deleterious event in aging, and to understand the limitations of protein and amino acid supplements in the context of aging. So why protein and why muscle? I would say it would be fair that for the first sort of 15 years I was at McMaster, we were really interested in what happened with protein and interaction with exercise in younger people. And that was awesome. It was great to try and get people to be as big and as strong as possible. And we learned a lot. And, you know, as I get older and research sort of becomes me search, I also took over a community access facility of about 500 individuals that come from the Hamilton and surrounding community into the university to exercise. And their average age is about 73. The oldest participant we currently have is 99. We did have a 105-year-old. You know, so it's been really interesting to sort of, you know, talk to these people and say, what is it that, you know, gets you to age successfully? They clearly value exercise. We talk about nutrition, but really, you know, what can we tell these folks? So the impact of sarcopenia, and it depends on which definition you use, is pretty high. But let's just say it's somewhere between maybe as low as 10% and as high as 60% in 80-year-olds. And the theory goes something like this, that at some point in your life, you're going to lose enough muscle that you're going to fall below a threshold. And it doesn't mean that things change drastically, but your risk for disability goes up quite sharply. And so clearly muscle matters, and that's one of the messages that I'd like to get across today. So, you know, a grad student drew this for me, and clearly this grad student believes that age-related muscle loss starts at age 50. Now that I'm well north of age 50, I think it's closer to around age 58. By personal observation, it's probably 59 next year. It just keeps getting older as I keep getting older. We don't really know why sarcopenia happens, but we're pretty sure that it's an interaction between hormones, blood flow, intrinsic skeletal muscle, metabolism. And then 2 factors that we do have control over are exercise and nutrition. The problem is that older people have a phenomenon of what's known as anabolic resistance, and it's akin to insulin resistance, and that is that as you age, you develop a resistance to exercise's usual robust anabolic effects, and those of nutrition as well. So including mostly protein, but obviously some other nutrients. So we wrote this perspective, and it's getting a little bit older now, but I think that some of the pieces that we highlighted in here still hold true today. And it was Dan Traylor, who was a postdoc in my group, who led this work. And we made the point in there that there are two, you can see them highlighted in blue, what are commonly cited nitrogen balance methods. And now this is currently still the method that is used and cited within the DRIs to establish protein requirements. But we need to be clear what it does. It actually defines the requirements for nitrogen to offset deficiency. Now, it includes a margin of error in that, but it doesn't allow for any interpretation of what it is that causes either deficiency or insufficiency. And it certainly doesn't allow for an understanding of what we call optimization. Now, the green methods that are highlighted here use a slightly different method, which is called the indicator amino acid oxidation method to determine protein requirements. And if we take a look at all of these methods, I'll just sort of highlight them for you. So this, the Rand, Pellet, and so Bill Rand, Peter Pellet, and Vernon Young is the foundational, if you like, meta-regression and nitrogen analysis method that is inherent in the DRIs that sets the current RDA for protein. So the protein requirements for nitrogen balance from the Rand paper were 0.83. Now, they only included 14 of 235 data points from older people. And they said, you know what, there's not enough data. There's no difference between older people. The Campbell paper said that nitrogen balance gave an estimate of about 0.85, so pretty close. But Humayun, who was working with Paul Penchards at the time, did a reanalysis of the RAND data, including some data points that they left out, and said, actually, the nitrogen balance estimate puts the requirement for older people at about 1.05. If you look at all of the indicator amino acid oxidation methods, they put the need, and I emphasize need, at about 1.2. So if we took all of these at face value and just averaged them out and weighted them for the number of subjects, we get an average protein requirement need now of about 1.16, or just shy of 1.2. So 50% already above the current RDA of 0.08 grams per kilo. And that's been reflected in a number of position stands to show that, you know, older people should probably be in this range here, 1 to 1.2 as a minimum protein intake. It may go up with acute or chronic disease, and definitely in severe illness or injury, and definitely marked malnutrition. Now, we did this analysis in the viewpoint that we presented to make the point to people, because you read in the press all the time and people, I don't know what happens, but seem to forget the definition between the estimated average requirement and the current RDA. And they say, look, you know, if this is really the estimated average requirement, women and men, and this is based on 3-day food records, there's really not that big of a deal. Maybe a few people are getting below, but most people are above, and definitely most people are above the RDA. But if you use our revised estimates of the estimated average requirement and proposed RDA, now you're beginning to see that actually a fairly large percentile of people, or only a small, percentile of people are above that, and a large percentile of people are below. And so maybe it's some sort of risk, and it may not be a risk for deficiency of a nutrient, but I think that there are tissues that are more vulnerable, and muscle obviously being one of them. We also know that aging is associated with a reduction in food intake, which is a predisposition to protein undernutrition, if not malnutrition. We also know that when you feed older people the RDA, they have a reduction in their muscle area and their strength goes down. So we've got interventional data to show that. So I put it to you that older adults need more protein than the RDA, at least 1.2, to maintain their muscle mass. And we may see even greater benefits with higher intakes. And many older adults are not consuming these intakes. And here's a list of reference. And I'll just say flat out that, you know, people are welcome to have these slides, and I'm happy to send a copy of them if you just fire me an email after the talk, no problem at all. So some takeaway messages: sarcopenia is relatively prevalent. Protein needs for older people are higher than the RDA by at least 25 to 50%. And that's need, I emphasize need, and that's not optimization by any stretch. Many older people may be consuming the RDA for protein, but that appears to be inadequate. And besides, it's irrelevant and based on a method which I think is long overdue for revision, which would be nitrogen balance. So let's talk a little bit about muscle protein turnover. And for years, we've used stable isotope tracers. Steph has used the same sort of methods, and we've all collaborated. And I learned a lot from my postdoc mentor, Bob Wolf, made tons of friends during that area. Still collaborate with Arnie Ferrando, now David Church down at the University of Arkansas Medical Center. And it's a true pleasure to call those people both friends and collaborators. And we often use this figure. It's an easy one for me to draw because I drew it because sine waves are easy to draw in PowerPoint. And it goes something like this: that if you're consuming protein at breakfast, lunch, and dinner time, the variable that changes more is muscle protein synthesis, shown in the yellow here. It goes up and then comes down, and then you eat again, it goes up and comes down. And muscle protein breakdown really doesn't change too much. It just sort of wanders back and forth. This is in healthy folks. Now, as the graph implies, this will be the same amount of protein and sort of temporally spaced equally across the day. And we know that that's really not how things happen. But nonetheless, schematically, it's designed to show you that protein anabolism occurs for a short period of time. That's the area of green. So we're gaining a little bit of protein mass. Then we lose a little bit. Then we gain a bit. We lose a little bit. And, I think empirically, when you look at people from probably about age 20 to maybe somewhere in their 40s, they maintain their muscle. And this is what's going on, assuming that they're getting adequate protein of adequate quality. Now, what happens when we add exercise, and the exercise we're going to add is loading exercise, so resistive exercise or something to increase the mechanical load on the muscle, we get an enhanced anabolic effect, and we get a diminished catabolic effect. And so it doesn't take too much to recognize that if you lift weights and you load the muscle for long enough, you can accrue or gain muscle mass, or if you're an older person, you would mitigate the loss of muscle mass. So in the opposite direction, what happens with aging, and this sort of comes back to some work that we try to do to estimate what the per meal protein dose was. And these are some data from Dan Moore, former PhD student of mine. And what Dan did was actually retrospectively go back and look at all the data we had in young individuals. These were average age of about 22, and older individuals, average age of about 72. I should mention these are all men. We do have the data in older women, and I'll show you that a little bit later. And what you can see is that we've used this, what's called biphasic linear regression model. So we've plotted the data up to the point where it plateaus, and then forced a flat line through here and look for this inflection point. The inflection point occurs at about 1/4 gram per kilo per meal. That's the 90% confidence interval. And you can see that it's much further shifted to the right at about 0.39. So almost 70% greater in older individuals. A wide confidence interval, but probably because we've got much fewer data points. Older people, however, do get to the same rate of protein synthesis. These are the force-generating proteins inside muscle. And so it's an indication that older people on a per meal basis need more protein to get the same rate of new muscle protein synthesis. So if you were to plot it in those same type of curves, instead of getting this robust anabolic response with each meal, when you're older, you get a diminished anabolic response, but you still get the same catabolic response. And it's this age-related, what we refer to as anabolic resistance, that in our mind is one of the key events that occurs with aging and is responsible for muscle loss over time. Now, what causes it? This is a picture drawn by James McKendry, a former postdoc of mine. And, there's lots of mechanisms. It could be due to an impaired digestion and absorption. It could be due to inflammation, blocking, or it could be proteolysis or protein synthesis. It could be due to microvascular impairments, reduced physical activity, something intrinsic to the muscle. We really don't know. But what we do know is that if we reduce activity, even in a younger individual, we can make their muscle anabolically resistant. So we think that the activity level is one of the key drivers of this anabolic resistance. And, you know, it's not probably too much of a surprise because everything, when you go from earthworms all the way up to human beings, cats, dogs do the same thing. As they get older, they simply do less. And so that's a part of, we think, a key part of this process. Sarah Oikawa drew this figure for me. Sarah was a PhD student in the group, and what she's done here is shown you what really happens in real life, at least in North America. Older people consume a small amount of protein at breakfast, usually somewhere in the neighborhood of 10 to 12 grams at around 7 in the morning. And so they only get a small response here in protein synthesis. And so they may get anabolically positive for a small amount of time. And then they eat a larger amount at the lunchtime meal, but they eat the largest amount of protein at their dinner time meal. And they may have a pre-bedtime snack here. So if these are sort of 4 meals per day, you can see that the small meal might not actually hit the protein threshold that's necessary. Now, there it is for a younger individual, and this would be a male of about 85 kilos, about 20 grams of protein, and they're hitting it at the lunchtime and dinner time meal. In fact, they're exceeding it at the dinner time meal. But if you're an older individual and you go up to that higher level of intake needed, you may only hit that intake level once. And so these would be perhaps not a positive anabolic effect. And we should redraw these curves as showing just something minimal here. And this may be the only time that you get a positive anabolic effect in an older individual. So older adults have greater per meal protein needs to stimulate protein synthesis, and these imbalanced per meal protein consumptions are a suboptimal way to consume protein. So what's the active amino acid? I know obviously we know we need all of the essential amino acids. They're listed there on the left versus the non-essentials, and we're assuming that we can make adequate quantities of those. But there's one amino acid in particular, and that's the amino acid leucine. I know you all remember that it's a branched chain amino acid. There's its structure. It triggers a canonical signaling pathway through a very highly conserved protein called mTOR C1, which results in lots of different things, but namely protein synthesis here. And at the same time, we know through the work of David Sabatini's lab at MIT how this works. Leucine binds to a protein called cestrin-2, which relieves the inhibition on this mTOR complex that binds close to the lysosome. I'm not going to go too deep into the mechanisms here, but we know how this works. And it probably goes something like this, is that we need to get the leucine within a cell to fully saturate all of the sites on cestrin-2 to get a full anabolic response. And I'll just show you some data that we've developed over the years that would probably illustrate that leucine is particularly important. So this is Tyler Church-Rubinet, at the time a PhD student in my group, and we've got 3 conditions here. This is the negative control group. So we've got a small dose of whey protein. Then we've got a large dose of whey protein. Then we've got the small dose of whey protein to which we've added back a large dose of leucine. This is way more than you would get in 25 grams of whey, but this is a proof of concept trial, if you like. And this is muscle protein synthesis in a fasted state. They ingest these protein sources. Protein synthesis goes up in all 3 conditions, but it remains elevated, and it's already sort of returning back to baseline in the small dose, remains elevated in the large dose, or about 4 times as much as the 6-gram dose, and in the 6-gram dose to which we've added back the leucine. So the leucine, if you like, keeps the process turned on, and you have enough essential amino acids in that 6 grams of whey to perpetuate this protein synthetic response. This is all after exercise, and so maybe it's an exercise-induced process as well. So we decided to, in older individuals now, men and women, look at this process, but separate out the effect of the leucine itself from the exercise effect. And to do this, we get a little bit cute, and we only have them exercise one leg. And so there's a within-person control with their opposite or contralateral limb. So it's a bit contrived, but it allows us all within one person to test a number of different conditions. And then the between variable are obviously the different people. So these are the data from Keelan Murphy, who was a PhD student of mine at the time. And we had people consume a lower protein intake. This was the RDA, a higher protein intake. This was the 1.2 grams. And this is the rested leg. And with every meal, they ingested 5 grams of crystalline leucine. And we did this in a double-blind manner. So we had a placebo, and at the same time, we had a leucine drink. And you can see that in the rested leg, the leucine supplemented group, everybody got a greater anabolic response. Now, this is protein synthesis. Sorry, I should have mentioned this over a period of 6 days. So this is using a slightly different method that we used before, which is just measuring protein synthesis over hours. This is a per day measure now. We take biopsies days apart from the muscle to get these measures. Resistance exercise leg here, you can see crosses or daggers here. Exercise is always beneficial, even in the placebo group, but we get an even greater anabolic response in the leucine supplemented group, even with exercise. And so it's adding again to the anabolic effect, and this is seen over a number of days. So this is a large amount of leucine again. So this would be a proof of concept trial. These are older men, average age of about 72, disease-free, some medications, but nothing that I would consider to be too important, mostly to regulate blood pressure and some medications for BPH, for example, but no statins, no anti-diabetic medications, nothing in the realm of sort of, corticosteroids or anything like that. So relatively healthy older people. We've done this in older women too. This is Michaela DeVries, who was a postdoc in the group at the time. And we used the rest and exercise leg to get the comparison here. But what we did this time, instead of supplementing each meal, we actually incorporated 2 leucine-enriched beverages within the diets of these women over the period of a week. So this is week-long protein synthesis, or excuse me, this is protein synthesis in percent per hour, but we've got the same data over weeks. And you can see that in the rest condition, the leucine augments the anabolic effect. In the exercise condition, there's always a beneficial effect, but it's greater in the leucine supplemented group. So these women got exactly the same amount of protein and exactly the same amount, the same quality of protein with respect to, or with a difference only for the 2 enriched leucine beverages during the protocol itself. So there's the major difference between the 2. So we've seen it in young men. We've got the data now in younger women. We've seen it in older men. We've seen it in older women. And leucine is really the key or the trigger amino acid. And this is really how we think, at least, that it works. So the intracellular leucine has to rise to a certain concentration, saturate all those sites on cestrin-2 to create or meet this sort of threshold. But it's not really an on-off, like light switch type threshold. I prefer to think of it as a dimmer switch. And so, some leucine will turn the light on a little bit, but a lot of leucine will sort of turn the light on as bright as it can get. The key is, though, that the trigger is mobile, and the mobility in the trigger is induced by exercise. And exercise transiently, then, we think, moves those 2 complexes to closer spatial proximity to each other to trigger the catabolic effect of protein synthesis. But the trick is you have to keep exercising to keep this going. Now, if we get somebody who's diabetic, or we take a younger person and we put them on bed rest, or what we usually do sometimes is we put a cast on one of the legs of these younger people, we can send the trigger in the opposite direction. So that would mean they either require more protein or, more specifically, more leucine to trigger the anabolic effect. And so this threshold, if you like, is mobile. And this is an important paper. Sylvia Zwiga is this young lady on the left. This is Glenda Courtney Martin, good friend of mine, and dietitian down at Sick Kids Hospital in Toronto, a former student of Paul Panchart's and Ron Ball, who developed the indicator amino acid oxidation method. And they showed that the leucine requirements for older men and older women were twice what is currently recommended. And their conclusions, and just taking directly from the abstract, is that the estimated leucine requirements is more than double the amount in current recommendations, suggesting that leucine could be a limiting amino acid in the diet. And they also talk about the potential peril or downside of plant-based diets and the structural role of leucine in muscle protein synthesis. So just thought I'd mention that because I think it bears some relevance to what we're talking about here. And to remind all of you that not all proteins are created equal. I'll give you the acronyms here. This is whey protein isolate, milk protein, soy proteins, pea protein, rice protein, and collagen. I put collagen on there because collagen is now being put into a ton of supplements for older people. I think it's a real injustice that it has a protein quality score itself of 0. And the only way to make this better is to either add one of these complete proteins or add a bunch of crystalline amino acids. But just to quickly show you that the leucine amino acid reference ratio, you'd have to consume almost twice as much soy or pea, a little bit more rice, but 4 times as much collagen to get up to the same level. So you could do with less protein here what you need more protein to do with here. So leucine is a critical amino acid in switching on muscle protein synthesis. When added on top of normal protein intakes, can augment muscle protein synthesis. The leucine requirement may be twice as high as is currently recommended for older individuals. And not all proteins are created equal in terms of their leucine content. So what does all of this mean? Well, when you come from McMaster University, the one thing that we're really known for is we're being the home of evidence-based medicine. And so thanks to David Sackett and his student Gordon Guyot, who were using evidence-based medicine to decide, for example, what was the best adjuvant chemotherapy for curative rates in cancer, that you can't simply look at one study and sort of come up with an answer. You have to look at a number of different studies. So evidence-based science, hopefully to the rescue here. This is Everson Nunez. He's a postdoc with our team. This is, I think, a pretty good meta-analysis that was published a couple of years ago now. 74 randomized controlled trials, 2,300 individuals. We looked at the effect of supplemental protein either as a whey or a pea protein supplement, or more protein containing food, and in older and younger individuals. Now, I'll cut to the chase because there's a lot of data in this paper, but I'll give you the take-home points here. I know you can't see the forest plot here. The rhombus at the bottom for showing an effect of protein is shifted to the right. So protein is beneficial, but these are all the studies that combine protein with resistance training. If you just eat more protein, there's no effect. So it only works if you're lifting weights. And that's the only way, because most of these trials are short-term, that we could see the difference. There is an age-related difference in if you were older than 65 years, the effect got a little bit smaller. It was statistically significant, but only barely so. And the difference in sort of real numbers is about 0.5 kilo. Now, it's 0.5 kilo of lean mass. And everybody says that's muscle mass, and it's not. So lean mass includes muscle, but it also includes water. It also includes organs. It includes, even if you use DEXA, the non-mineral portion of bone, because 40% of your bone is actually protein by content. And so people look at this and say, oh, that's muscle, that's great. And that's not the case. So just bear that in mind. It is a dose response. So when we break it up into small studies that supplement and get people to less, above the RDA, but less than 1.2, we actually don't see an effect. If it's somewhere between 1.2 and 1.6, It's not actually significant in younger people. It is in older people. But when we get to about 1.6, this appears to be sort of the sweet spot where we're getting absolutely everybody over and above and shifted to the right overall here. So here we get about 0.7 kilos. So that's a larger effect than we see overall. But probably only about half of that is muscles. So it's a little bit less than a pound. But again, this is all with resistance training. Okay, so just bear that in mind. But it is a dose responsive phenomenon. To date, however, no intervention trial has ever shown an effect of protein in improving mobility, muscle mass, or function in healthy older adults when exercise is not included. And, that's an interesting message because we do have observational cross-sectional data to suggest that protein is beneficial. Now, there is one intervention trial that has tried to address this, and I'm going to take a run at it right here because it says that the conclusion is that the RDA for protein is sufficient to maintain lean body mass, but it wasn't powered sufficiently and it wasn't long enough in duration, and I'll just show you what I mean. The protein or the intervention here was high protein, so it was 0.8, the RDA, and 1.3, and then they had the same interventions with testosterone. Now you can see the change in whole body weight, you can see the change in appendicular lean mass, and you can see definitely that testosterone works, but that there's no effect of protein. It was only 6 months in duration, and I'm not sure why these researchers with these types of study sample sizes would believe that they would see a difference, but they did make the conclusion that the RDA was sufficient. When you go back and you look at these two this is the registration for that trial over here. And we made the comment in a review paper that when you look at the statistical analysis plan, we said that the hypothesized gain in lean body mass over 6 months in both group of men consuming the RDA was approximately 1.3 grams per kilogram body weight. And you'd need about 2,000 older adults to see this. And so I don't see how they were expecting to detect this. It was definitely well powered to detect the effect of testosterone, but it was not powered sufficiently to see the effect of 1.3 grams of protein in a 6-month period versus the RDA, and definitely nothing to do with functional status. We have data, and these are two of them, to show that when older people consume the RDA, they lose muscle. So that in and of itself, I think, is some proof that the RDA is insufficient. At the same time, we have a number of trials, and this is just a small selection of them, that show associations of muscle mass and function and protein intake. And all of these are above the RDA level. And I'm just going to give you this systematic review and meta-analysis. This is of observational studies, is that a very high, and they call that 1.2, and high protein intake are associated with better lower limb physical performance in community dwelling older adults. But they say that large randomized clinical trials are needed to confirm the additive effects of high protein diets in comparison. I've done some back of the envelope calculations as to what it would take to see this effect. It's at least a year-long intervention, shorter if you have more people, but I estimate it would require about 200 adults per arm, and we would have to clamp feeding. So if you know somebody that wants to support that trial, please let me know. I'd be happy to help you out. Needs to be multi-center, of course, to do something like that. At the same time, and this is, I thought, was an interesting paper because it's a systematic review and meta-analysis of observational studies, is that a high, they said high, I put the here, high protein intake was negatively associated with frailty status, and that's the odds ratio. So the more protein you had, the lower risk of frailty you had, suggesting that a high consumption of dietary protein is inversely associated with frailty in older adults. Now, again, observational studies, it is a causality. We don't know. But I think at least it's indicative that if you go for long enough, you maybe don't need to have exercise be part of the criteria. What exercise does is actually enhances the effect and allows you to see it in a shorter period of time. There are, however, and I use this trial to sort of make a point, cases where you can augment lean mass and performance in individuals, but you need to start with individuals that have a low relative function. Probably these individuals are unwell. So these are frail elderly subjects, and a lot of them were undernourished. And so we've got a dose response going from the RDA to 1.2, and then from 1.2 to 1.5, so close to the 1.6 that I'd probably recommend. This is appendicular skeletal muscle mass assessed by BIA, so not my favorite body comp method, but you do see a dose response here. This is what happens when you divide it by weight, and so you can see it enhances the response. We've got this sort of staircase, and interestingly enough, when you look at the functional outcomes, I'll just highlight this for you here. Going from, this is gait speed. And, you know, if there's one or two things that come up consistently as remarkably robust criteria for predicting longevity and freedom from disease. One is hand grip strength, probably because we have so much data from that. And the other is gait speed. And you can see that you do get a little bit faster when you train. So these people were measured. So this is probably the learning effect. But you can see going from about the same to about 1.09. So this is a statistically significant difference between the groups at week 12. But you need to start out with people who are in probably pretty rough shape to see this in a short period of time. Healthy people, you just don't see anything like this. You need much longer or more people. So resistance training augments the gains in lean mass, and protein helps a little bit, but it's a thin slice. It's the resistance training that really does the job. The protein effect is dose dependent, requiring intakes of greater than 1.2 and probably up to about 1.6. We don't yet have an intervention trial. Although one trial attempted to make the conclusion, but I think it was poorly designed and didn't have the sufficient sample size. Observational data shows that higher protein intakes are associated with improved lean mass and reduced risk of frailty. But in more vulnerable older patients, either frail or pre-frail, definitely undernourished or malnourished, then protein does augment lean mass in a dose-dependent fashion and function as well. So I think you can probably argue that we could have an impact in some populations. I want to talk really quickly about muscle disuse, and I know I'm getting towards the end here, so just bear with me. Let's just say, and I've shown you this model of wearing this immobilizing knee brace, which is what we use in younger individuals, that we were the first to identify that you could immobilize one leg and you could make the change happen in only the one leg, and the non-immobilized leg was fine. But the resting fractional synthetic rate of protein synthesis went down, and only in the immobilized leg. So it's really an effect that's confined to the one limb. We identified then that when we infused amino acids, and we really got the amino acid load up high here, we had a low load amino acid effect as well, that we got the response in the non-immobilized limb was much greater than the immobilized limb. This is the fractional synthetic response in the non-immobilized versus the immobilized limb with the high dose and the low dose. So it didn't matter whether you were using high or low dose amino acids. But the bottom line was that you essentially got anabolic resistance in young individuals, men or women, didn't matter, with inactivity. Take the brace off and it comes back pretty quickly in younger people. Take the brace off in older people, and it takes a long time to restore this. So this meal-induced, if you like, anabolic resistance is really something we can recapitulate in younger individuals with disuse. If we do it in older people, it takes a long time, and it probably represents in some individuals a permanent loss, as I'll show you. So what might we do to mitigate this muscle loss? Well, clearly, activity. And so, here's somebody who is actually intubated and walking around the ICU, so they're ambulatory. We try and get patients up as quick as possible after surgeries. If we can't get them up or they're immobilized because of the extent of their injuries, we can use neuromuscular electrical stimulation. And this absolutely, and I mean absolutely, trumps any nutritional intervention you can do. Activity is so powerful in its effects. Nutrition simply adds on top of that. So at the same time, we have using, this was an experimental formulation that was derived from by a company called Excella. And you can see the composition of it here. So really rich in leucine, some other essential amino acids, and some thiol antioxidants. And we showed that in younger men, anyway, through 7 days, you got less atrophy, so less of a change in muscle volume and cross-sectional area. And even 28 days later, after you've taken the brace off, it was still sort of a little bit less, but definitely preserved in the high-dose amino acid group. Now, they were consuming this supplement 4 times a day, so bear that in mind. It's a lot of leucine and a lot of essential amino acids. At the same time, we've fed, this is in younger women, omega-3 fatty acids. And so preceding the disuse period, we loaded people with high-dose omega-3s. And you can see that the change in cross-sectional area, of the quadriceps was less in the omega-3 group. And then removing the brace, you get a better recovery in that group versus the placebo. You can see it from a leg lean mass standpoint. In fact, in the first 7 days, we couldn't even detect a change in leg lean mass. It went down, but then was completely restored, and strength returned more rapidly in the omega-3 loaded group. So big tribute to my good friend and colleague, who passed away way ahead of his time, in talking about what he called the catabolic crisis. And this catabolic crisis results as a result, if you like, of bed rest or some type of disease or some type of hospitalization. And Doug Patton-Jones, made the point that you can see that this difference now after this sort of rapid acceleration and decline is almost a permanent one. You're almost on a slightly different family of lines, and you would have to work tremendously hard in rehabilitation to try and get back here. So emphasizing the point that if we had these individuals prior to 50, they would see this dip, but they would come right back up. But after a certain age, it becomes very, very difficult to rescue this muscle loss. So one of the things that Doug and Kirk English, who is the first author of this paper, and Don Lehman have sort of stressed or emphasized is that we need to intervene early to try and prevent the decline and mitigate the loss rather than trying to reverse it afterwards. And so this was a paper that Doug and Don and I wrote, essentially trying to sort of say, you know what, we really need to do something in here. Physical therapy would be the front line. Introduce it early, introduce it often, mobilize patients as early as possible, and have protein ingestion in close temporal proximity to the physiotherapy. So it's no good having your PT and then sitting around for 4 or 5 hours on bed rest before you have the meal that's going to enhance the anabolism. You really need to do the two together. We could add other ingredients. I've told you about high-dose essential amino acids, told you about omega-3 fatty acids, but we could talk about things like creatine and possibly other bioactives to enhance that effect. And the idea is to mitigate the decline in muscle mass, but mitigating the decline also maybe in mitochondrial function, because this is something that happens very early on, and in people who have an impaired mitochondrial function to begin with because they're older or because they have some type of metabolic illness, and to try and help them recover. So high-dose essential amino acids may mitigate muscle loss in short-term scenarios, but we definitely need more data here. I've been pretty provincial, showing you only our data, but need to acknowledge my friend and colleague Luc Van Loon, because some of his data from his group indicates that high-dose leucine and some other essentials didn't work. But again, Arnie Ferrando and Bob Wolf and their group have shown that it might help. We think high-dose omega-3 fatty acids before disuse may mitigate lean muscle mass. So you'd have to know that the disuse event were coming, but that could be prior to elective surgery, something like knee or hip replacement, and it could be before something like elective colorectal cancer surgery. This catabolic or disuse crisis in older people is a major watershed event. In fact, I think if everybody sort of just aged gradually and didn't have any of these disuse events, they would be fine. I think the disuse event is a real watershed moment for older people. If any of you have ever seen somebody who's gone into prolonged hospitalization for whatever reason, doesn't matter whether it's elective surgery or because of an accident or something like that, then you'll know what I mean. And hip fracture is a great example. They would definitely benefit from early aggressive mitigation strategies to prevent muscle disuse rather than trying to rescue the event afterwards. So some take-home points. Older people need to consume more or higher quality, at least higher leucine and essential amino acid protein at each meal. And they need to practice loading or resistance exercise. And it's not that walking isn't a great exercise. It's fine. It's definitely a great cardiovascular workout. But at some point, strength and power are going to limit your daily activities. So you need to be stronger. In fact, you need to be stronger and to develop that force quickly. That's power to do things like walk rapidly, get across an intersection, rise out of a chair, ascend a flight of stairs, descend a flight of stairs in safety, open a car door and get out of a car, carry certain things, for example. Higher protein intakes are associated with improved lean mass and retention, physical function, and a reduced risk of frailty. These effects are compounded in disuse scenarios, but we do not have interventional data to show that protein will do something here unless we take people with reduced function to start with. So we need to make efforts to mitigate the loss and not likely to be useful unless activity is increased. So we need to introduce activity as soon as possible. If all the benefits of protein highlighted here are correct, then what we definitely need are larger, longer-term interventional trials to show a benefit. That could include exercise or even mild exercise. It doesn't have to be, go to the weight room and lift really heavy weights, chalk dust and weight belt type workouts. It could be something comparatively benign, but you can see the power of the exercise in enhancing the effect of protein. If we want to talk about protein alone, then we need about 200 or 300 people per arm. We need to control feeding almost the whole time, and we would need something that's about a year long in terms of intervention. So I want to say thank you very much for your time. Hopefully there was something new in there, and definitely I've got a few minutes left. I can hopefully answer a few questions for you.
Dr. Phillips, thank you. That was an incredible amount of information and data to absorb. And there are, in fact, lots of questions.
Okay, all right.
Perhaps what I can do, because I don't think that in the remaining 6 minutes to the hour, we can get through nearly all of them. I'll start at the top, but perhaps I can send them to you. And to the extent that we can identify the people who's asked them, we can get back to them.
Right.
If you can do that, that'd be wonderful. So let me start at the top with the earliest question in, which got a thumbs up. Are older adults' kidneys able to handle the increased protein without adverse effects?
Yeah, so we got to burst this bubble. Here we are 60 years after the Brenner hypothesis. We've had about 4 meta-analyses now. We did one, and we've never been able to see with an intervention trial a decline in kidney function. So when we look at observational data, the same systematic reviews would find the same thing. In other words, and even the WHO and the DRIs agree that the age-related decline in kidney function is not related to protein. Now, if you have somebody with type 2 diabetes, maybe you need to be mindful of this. But we need to absolutely squash, and I mean squash the concept that protein is causing a decline in kidney function. because there's still no evidence that that's the case. So I know I'm soapboxing here a little bit, but it's 50 years after the Brenner hypothesis now, and we have no data. So I think it's high time that the hypothesis get chucked out, to be honest with you.
What about, and I'm trying to ask, for the person who asked this question, Denise Van Wissen, what about people who have impaired kidney function to begin with? Can they handle these?
Well, absolutely. I mean, it's that's imperative, right? But the key with people with impaired kidney function to begin with is to emphasize the highest possible quality proteins that you can to preserve what muscle they have. So, I mean, we know people who are on dialysis are going to lose muscle mass because of removal of a lot of the essential amino acids. So the message should be eat as high as possible the highest quality proteins that you can get to preserve the muscle mass that you have.
And this is a moderator prerogative question, despite all the ones that have been sent in, which is, given thinking about sustainability and carbon footprints for animal-based proteins, can the same, is one of the things that you would want to test in a clinical trial, whether you can achieve the same benefit by adding leucine or a combination of essential amino acids to plant-based proteins?
Yeah, I think it's fair to say is that every trial so you get a different answer of me today than you would 20 years ago. 20 years ago, it was like, oh, protein quality scores, animal proteins, much better than plant proteins. Now, with processing, and that's the key step, and removing some of the anti-nutritional compounds to take away the digestibility issue of plant-based proteins, we've got plant-based foods that are actually pretty digestible. And when we combine proteins and we get our grain and our legume, we've got some plant foods that are actually very high quality that I don't think it would make any difference if you ate those foods as opposed to the animal-based proteins. So I agree that you can do that, but I'll say this, and it has a caveat. If you believe that ultra-processed or processed foods are not good, these are the foods I'm talking about, because in our analysis of young people, particularly who are vegan, they are eating the highest proportion of processed foods of any age bracket that we have surveyed because of these products. So I'm at a bit of a loss as to whether that's good or bad, but I definitely think that more plant proteins probably better in the longer run. But I'll admit that I'm an omnivore and dyed-in-the-wool omnivore. So, but I probably eat a lot less animal-based protein now than I used to 10 or 15 years ago.
And there was actually a fabulous set of webinars a week or so ago that I heard that was a lot of people at NIH attended, I think, suggesting that perhaps not all processed foods are the same.
Yeah. No, absolutely. The sound of David Jenkins ringing in my ear saying that these plant-based milks that we have probably don't deserve the bad label as an ultra-processed food. So I would definitely agree that there are ultra-processed foods and then there are ultra-processed foods. So chips and Twinkies probably not so good. Plant-based meats, plant-based foods. I hand on heart, I can say probably okay. So no problem.
And I've run down the clock all by myself. I apologize. Here's a more pointed, treatment-oriented question. What weight do you use to determine protein needs? Is it the ideal body weight, the actual body weight, the lean muscle mass?
Great question. So here's what I do. I don't look at ideal body weights. If you have a BMI of 30 or below, I use actual weight. If you have a BMI of 30 or above, I just take the weight that would give you a BMI of 30 and I use that. I don't know if there's anything clinically great about that, but that's how I prescribe protein to people who have BMIs north of 30. I think this ideal weight concept is not the way to go, to be frank.
Or at least it should be more personalized.
Yeah, something like that. And I mean, I don't want to suggest 1.6 for somebody who has a BMI of 45, right? That would be crazy. They would be, 60% of their energy coming from protein. So yeah, too much.
We are at the hour. I don't want to abuse the privilege of having your presence. I know you're just back to stateside. So I want to thank you tremendously. Lots and lots of questions, and I will save them, and we can try to share the answers with everyone who attended.
Yeah, and I think, Barbara, did we not agree? Like I said, the slides can be available to anybody, no problem at all.
Oh,
So
did you
can,
say anyone?
yeah, anybody. Like, so if you like, just share, if you could share the PDF,
My
no
notes said
problem at
put
all.
some limitations on who you could share them with.
Oh, yeah, I can't remember. Wow. Okay.
Up to you. Let's check in on that.
Sure.
Okay.
Awesome.
All right. Thank you so much for a fabulous seminar.
My pleasure.
We had well over 100 people in the end. So and lots
Awesome.
and lots of questions and enthusiasm. So thank you so much for doing this for us.
You're very welcome. It's been my pleasure. Take care.
Thank you. You too.
Bye-bye.
Bye.